Good morning, everyone. So, can you see my screen, right? Like
Yes,
I'm
we can
seeing
see
it.
your screen. Now, can you open your PPT? Can you put it in the presentation mode?
Yeah, sure. One more, please. Okay, so what we are going
Perfect.
to discuss today is we have a problem here in the dental field, particularly in the orthodontic field.
Andrew, sorry
Yeah.
to interrupt you. Can you just minimize that side window?
Ah,
where,
sorry.
yeah,
Yeah.
perfect. Go ahead.
Yeah, perfect. So what I was actually discussing when I started my residency in the orthodontic department here in Cairo University, we had a problem that we have these young children that are still suffering from skeletal discrepancy, particularly the upper arch, which is the maxilla, being deficient in the growth. And the only way that we had to do so to correct such problem at very young age while the patients are growing was actually to put an extra oral device, which is the face mask. And this actually affected a lot of children, particularly towards their social appearance and toward actually how they are going to deal with their friends in school and etc. So that's why we are trying to find a solution for that to be an intraoral device without going through a surgery, because sometimes patients have to go through a surgery to place something called bone plates in order to help with the protraction of the maxilla. So we wanted to do a simpler version for that without going through surgery. So let's first discuss our problem here, which is what are the patients what we are talking about. They are the growing patients. They have to be growing, and that we know that from something called a cervical vertebrae maturation stage, where we can know how much of the growth is left for these patients. And they have to be class 3 patients, of course, but with maxillary deficiency, because sometimes the class 3 patients, like they have a mandibular excess, not like a maxillary deficiency. So there is actually a very old concept that when the patients which are in class 3, when we leave them in such a situation, the condition usually worsens. But this actually, because they are thinking that because of the mandibular growth usually exceeds that of the maxillary growth, that's why this actually usually happens with time. That's why there was actually an old concept that we have to interrupt this actual problem extremely early and try to correct the problem extremely early. Okay, but actually there is actually a very cool study in China where they actually have these young patients, and they actually have followed up these patients from being in the growing stage toward to teenage stage, and they have done something called morphing. So this young patient have a class 3 problem. As you can see, the upper arch is behind the lower arch. So they expected by this old concept that we have like the mandible to be further ahead of the maxilla toward the end of the growth. However, when they followed up this patient after 5 years, the occlusion was the same. So we have to differentiate the patients that really require such treatment and patients that don't require such treatment, because this is extremely important, and this is causes a lot of an extreme intervention for these patients despite they don't need that. Okay. However, if you can see this other patient, we have a clearly class 3 problem. And after 5 years of additional growth, we can see it actually is the same profile. And this actually was a true class 3 patient rather than a pseudo one. Okay. So this is extremely important because we know that the growth of the maxilla usually ends before of the mandible because of the sequence of the growth. Okay, so we have to differentiate what we are doing right now. We don't actually normalize, we don't like intercept this growth in order to normalize the underlying skeletal discrepancy, because we cannot change the growth pattern of the patient. We try to correct the problem, which is the skeletal problem, for only for the maxilla, because the maxilla usually ends its growth earlier than the mandible. So when we interrupt such problem and we do maxillary advancement, and we know that the maxilla usually ends its growth earlier than the mandible, we have a very good results and stable results. But if we have this problem to be from the mandible rather than from maxilla, we know from the sequence of the growth that the mandible will end its growth later than the maxilla. If we treated these patients by advancing the maxilla and the problem lies in the mandible, usually the mandible will advance again ahead of the maxilla, and the problem would relapse. So this is extremely important to find out who are treating and who would benefit the most from this treatment. Okay, so our conclusion here, if the patient have a mild to moderate class 3, this actually early treatment is essential because at some point this will have a very stable result. However, if it was a severe class 3 problem with actually a severe mandibular growth is still lying ahead, it's preferably to wait until he actually completed his, to be in adult years and to do an orthodontic surgery instead. Okay. So the conventional therapy that we are discussing is the face mask therapy. And a lot of studies have actually shown that the face mask was extremely efficient in treating that, but it had a lot of side effects. First of all, it actually, because we rely on the anchorage on the teeth itself, usually we have a mesial migration of upper teeth, meaning that usually all of the upper teeth move forward along with the maxilla, and we don't have a true skeletal effect. Second of all, also this causes, or because we usually try to pull the maxilla forward, this usually causes a rotation of the maxilla around its center of rotation, and this causes the lower anterior facial height to be increased. How? Because we're having the palatal plane to be up from the front side and down from the back side, usually causes the mandible to move downwards and backwards. So we don't have a true forward movement of the maxilla rather than downward and backward movement of the mandible, resulting in a lower facial height to be increased, the patients to be having a very long face, and rather than a true skeletal effect from the maxilla being moving forward. So the solution that we have tried that to decrease the resistance from the maxilla to be able to push it forward. So the first solution was to use an expander with the protraction. And this usually was very efficient because having an expander that expands the maxilla along its sutures frees the maxilla slightly from these sutures and make it easier when we apply a protraction force to have a pure protraction movement of the maxilla rather than what we actually discussed, the conventional therapy. So having two screws anchored in the palate and then opening the maxilla, this actually helps to decrease the resistance, and this actually resulted in a very true skeletal effects. And this actually resulted in another thing that's called a V-shaped, a straight expansion rather than a V-shape. So what means by that? So when we use earlier the normal expander, which is not the hybrid means that I rely on anchorage on teeth and on the bone by using the mini screws. However, for the normal conventional expander usually resulted in more anterior expansion more than the posterior expansion. This resulted in a V-shaped form of the expansion. However, when we use the hybrid expander, we resulted in a straight expansion, meaning that we have almost equal amount of expansion anteriorly and posterior, and this is extremely important. So as you can see now, when we apply the hybrid expander, the end result that we have a very straight expansion, like equal amount of expansion anterior and posterior, rather than a very, very wide expansion anteriorly, like in the previous photos, rather than we had an equal amount of expansion anteriorly and posterior. Okay, so before that study, we had a current techniques, okay, with the skeletal anchorage. Either use a hybrid expander with the face mask in order to have a more skeletal effect on the maxilla, or to do a surgery and place a boom plate for the protraction in order to be in order to have to go through an intraoral technique. So the main problem with the face mask, as I mentioned earlier, that it was an extraoral appliance. So usually the young patients they actually don't like to wear these appliances, and this usually results in compliance problem, meaning that we sometimes the patients skip such important growth periods, and resulted that we don't benefit from such treatment, of course. And for the other technique, a patient has to undergo surgery. First for placing them into plate, and another surgery for removing it. So that's why it was particularly invasive. So what we did in order to help to ease the intraoral technique, we use a technique called an ALT-RAMEC. So the ALT-RAMEC technique is first proposed for the cleft patients particularly, because most of the cleft patients have the same problem, having maxillary deficiency, particularly if the cleft extends through the palate. And the patient has undergo a very early surgery, so that's why we have a collapse of the maxilla. So this technique was used. What's meant by this technique? It means that we do an alternate expansion and constrictions of the maxilla, so that we do a first round of expansions and second round of constriction, and going through that every week in order to free the maxilla from its circummaxillary sutures, so that would be easier for the protraction. So the theory of the ALT-RAMEC is explained first by Dr. Liu. He actually said that we have this maxilla and is actually anchored to the cranium through a certain centers of resistance where there are numerous sutures. And then when we apply the ALT-RAMEC, we actually resulted in having this, like the protocol, week 1 we expand, week 2 we constrict, and going through that until week 9. And usually we end up with the maxilla being expanded so that it will be easier in the protraction. This results in freeing of the maxilla from the circummaxillary sutures, and this would be easier to protract. Okay, and then after having the bone resorption at these sites, it would be much easier to protract the maxilla than the previous techniques. So this actually resulted in disarticulation of the maxilla from its surrounding sutures. So before doing this study, we needed to actually read enough research. So a very proper systematic review has actually asked a very important question: whether this ALT-RAMEC protocol was an effective protocol in treatment of class 3 malocclusion or not. Okay. The first study by Liu, he says that yes, it was very effective because it disarticulates the maxilla from the circummaxillary sutures, and this results in better effectiveness for sure of the maxillary protraction. And he says that the magnitude of the anterior maxillary displacement is about the double than the regular expansion. And it seems that now the ALT-RAMEC protocol is very effective, and it seems to be more influent than the type of the expander used, meaning that we don't need these extreme expanders that we normally use in order to effect a proper disarticulation. We can just do this protocol and have the same efficient disarticulation rather than going through a complex expanders. So what we have done here through the intraoral technique, of course, we have done like a study comparing the face mask rather than the intraoral technique, because like as I mentioned, the face mask was a gold standard, but it had a problem of the compliance problem, rather than it was a very simple approach, but it had a problem of being the patients usually refused to wear them. So we actually conducted this study comparing two groups of patients having the same expander going through the ALT-RAMEC protocol, and then we changed the type of the protraction, face mask versus the intraoral technique that we used. So our population here has to be growing patients, usually cervical vertebrae maturation stage 2 to 3, okay? And we, of course, compared the intraoral versus the face mask. And our primary outcome, of course, to see how much of the maxillary skeletal changes and correction of the reverse overjet. And the second outcome, which is the most important part, was to see the compliance of the patients and the acceptance of the patients to the post techniques. Okay, so for the overjet correction measured usually on the digital models, And for the other changes, skeletal changes, used something called lateral cephalomagnetic X-rays. For the patient compliance and acceptance, we actually use a patient satisfaction questionnaire, which is formulated earlier for different devices, and also child perception questionnaire for the age group of 8 to 10 and 11 to 14, because we relied more on the skeletal age of the cervical vertebral maturation 2 and 3 rather than the biological age. So as I mentioned, the main aim of that study, compare effectiveness of such a protocol using ALT-RAMEC that enables the ease of intraoral protraction of maxilla in these growing patients with maxillary deficiency compared to the conventional therapy of the face mask. And to see if this such a protocol can be used regularly for the treatment of such cases to enhance the patient compliance by limiting the use of these extraoral appliances. So this was the intraoral technique that we used. So it was the same expander used for the face mask group, but for the lower arch, we placed something called a lingual arch, and this usually hold all of the lingual arch together as one unit with extensions on the lingual aspect of the lower incisors and hold them together by a splint. And we use also two other mini screws in the lower arch between the lower lateral incisor and the canine, and a wire to be hanged from the labia surface of these teeth to the mini screw. And the main aim of the mini screws here is not actually to have a skeletal effect, but rather than to hold these lower anteriors, preventing them from severe retroclinations that usually can happen with because of placing like a very strong elastics, which you can see here, which are the class 3 elastics hanging from the lingual arch that we mentioned to the expander that is placed in the upper arch. So first of all, we needed to see where we could place the mini screws. For the hybrid expander, we relied on this study where it says there is a T zone where it like we have the most bone that we can actually place the mini screws inside, and usually it was at the first premolar region. And recommendation by Dr. Moon, who is an expert in hybrid expander, he says that we have to get a double penetration through the cortical plates in order to hold, so that we have a proper skeletal anchorage, and that would help us to have a proper skeletal effect. Because as I mentioned, we actually doing right now the ALT-RAMEC protocol, expanding and constricting the maxilla, so we have to ensure that we hold the maxilla properly, and we could actually do such technique. So we have two techniques for placement of the mini screws. Either we place the screws first or place them later. So what's meant by that? For the bin last approach, what we have done that we used a cone beam study, and we knew how much length, and how long is the screws that we need in order to get this double penetration, and we marked them on the models, and we constructed the appliance based on these marks, and then we bonded this appliance inside the patient's mouth, and then we placed the screws. This is the bin last approach. As you can see here. For the bin first approach, no, we do the cone beam, of course, and we place the screws according to this cone beam, okay? And then after replacement of the mini screws, usually we place something called like an impression caps. We place on these impression caps, and then we take an impression. Then we pour the impression, of course, to get the model. And you can see here we place something called lab analogs to have the ideal site of the mini screws as they were in the patient's mouth. And then we construct the appliance based on these analogs. Okay. This is actually was a pilot study that actually conducted such research. They have used the same approach, and they found that gain a very proper effect, but he didn't actually compare or compare these results to the face mask, or he actually has studied the patient compliance of the patients. Okay, so what actually we have done? So first of all, we placed the hybrid expanders, and we performed the ALT-RAMEC protocol to week 9. Okay, the week 9 meaning that we ended up with the maxilla being expanded, because this would be more favorable for the protraction. Then at the end of the protocol, for the control group, we delivered the face mask to start the protraction. And for our intervention group here, we place the modified lingual arch and the screws in order to start the protraction technique intraorally. And then we usually followed up the patient for about 6 months. So this actually our cases here done in the study. This was before and after of the treatment for the intraoral group. As you can see here, how much of the profile has improved. And of course, intraorally, the correction of the problem, correcting the reverse overjet, as you can see, the same overbite, meaning that we didn't change much in the vertical dimension. And this was particularly important because this was the main problem with the face mask earlier. As you can see here, how much of the improvement that happened. This was the extraoral group using the face mask. Again, how much is the improvement in the profile after using the face mask. And like the problem has been corrected. So both of them were equally effective in correcting the problem. And this also another patient, having class 3 problem, you can see how much of the profile has improved. And this is also another patient through the intraoral group. The main important change is the profile, of course, and how much of there is no vertical changes in the length of the face. This actually was the appliance intraorally, as you can see, the expander in the upper arch and the screws in the lower arch with the modified lingual arch. So it's actually a little bit like invasive in the face mask group, but still not as invasive as going through the surgery. And this you can see how much of the improvements that happened. So our results say that ALT-RAMEC resulted in some maxillary advancement even before starting maxillary protraction phase. And this actually shows how important is the technique for freeing of the maxilla from the surrounding sutures. Also, the patients in the intraoral group has finished the maxillary protraction phase faster than the extraoral group. This was because of the compliance problem. And we actually have 3 dropouts in the extraoral group refusing to wear the face mask appliance. And as I mentioned, this was particularly important to show how of the intraoral technique have helped the patients, particularly in this young age. So the patients were more compliant wearing the intraoral elastics. And the patients in the extraoral group were not satisfied with the extraoral device, which was a face mask. And this was based on the questionnaire that we have done at the end of the treatment. Thank you. So this would be the end of my presentation.
I have a few questions on your presentations from the audience. And the first question is, what were the main advantages of the intraoral maxillary protraction technique compared to the face mask therapy in your study?
Sorry, I didn't hear that properly.
Yeah. What were the main advantages of the intraoral maxillary protraction technique compared to the face mask
Yeah,
therapy
so
in
the
your
main
study?
advantage, yes, of course. So the main advantage, as you can see, both of them were equally effective in correcting the problem. And of course, the face mask considered to be simpler because it's an extraoral device and it is actually customizable. It is not having to be like we actually get it ready-made and customize it according to the patient's face. However, the other technique, we have like extra devices and everything. But the main advantage, as I mentioned, first of all, the patients usually were more compliant wearing the intraoral elastics rather than placing an extraoral device, which affected their confidence and, of course, their social appearance among their children and even their family. So this actually was one point. The patients at the beginning were actually compliant wearing them, but as you can see, we need at least 6 months of treatment in order to get the results. So patients usually drop out and refuse to wear them. This is many patients reported that it was easier to just place the elastics anytime that I want to, rather than placing an extraoral device. This was actually the main advantage. So mainly the compliance of the patients and the acceptance of the patients to the therapy.
Wonderful. Thank you so much. That answers the question. Just one last question for you. What future research directions do you believe are needed in the management of class 3 malocculation with maxillary deficiency?
Sorry, I didn't hear that. Sorry.
What future research directions do you believe are needed in the management of class 3 malocclusion with maxillary deficiency?
Yeah, so the future research right now usually would rely more on which patients should we treat and which patients are not, and also for the stability of the results. Because as I mentioned that we have done a lot of research in the past years regarding the treatment, but not of a lot of research focused on the stability of the correction. So that's why I have started our presentation with which patients should we treat and which patients will not benefit from such treatment. So we need to focus more on that rather than on the actual treatment. Yeah.
Wonderful. Thank you so much, Andrew, for your
Okay.
time. And this was
Thank you.
indeed a wonderful presentation for the audience as well. Wishing you
Thank
a
you.
very bright future ahead. Thanks so much.
Thank you a lot. Thank you.